My question is more about gastritis and CRP levels. I am on a healthy plant-based diet. I have no ulcers, but struggling with persistent gastritis for many years and RA. All my markers are good, except CRP is about 3 and 6, and sedimentation rate is a bit high. I try to reduce stress levels. Also, I am sensitive to probiotics and a lot of food. Could you please tell me what would help?
So, good question. So, when patients ask about gastritis, first I want to go back and sort of to define what that actually means, because gastritis is technically a histological term, which means it's not a diagnosis of anything. And so that's something that you can see, a little bit of sort of inflammatory cells if somebody takes biopsies of your stomach. There's no other way to sort of diagnose or to be able to have um, a diagnosis of gastritis, right? So that's the first thing. So I think a lot of patients, if they have abdominal discomfort or they go to the emergency room will say, oh, you just have gastritis. And that's not technically a diagnosis. So, and it's something that is usually caused by something else. So if somebody takes a lot of NSAIDs, for example, that can cause a gastritis, right? If somebody has a H. pylori infection, that can cause a gastritis. Particular medications can cause a gastritis. And the term gastritis just means inflammation. It just means inflammation of like the lining or cells of a particular, you can have inflammation anywhere of the knee, of the gallbladder, cholecystitis, anything can have sort of increased inflammation. So the first thing I would say is it endoscopically proven actual gastritis? And then understanding that that is sort of just from it's just a term from a pathologist. That doesn't, some patients will have a little bit of redness in their stomach when we go in for an endoscopy. And that doesn't mean that they have symptoms, doesn't mean that there is anything wrong. You can just see a little bit of redness or a little bit of inflammation. So first it would be making sure there's no medications that are contributing. And then making sure that you're not on, like, especially NSAIDs are a big one. And then also make sure there's no H. pylori or anything like that that can also contribute to sort of that diagnosis. And so, and as far as the CRP, I think I heard you say you had a diagnosis of rheumatoid arthritis. That is an inflammatory disease. And so that would be something that definitely to chat with your rheumatologist about, because that can be seen with just in the setting of having an inflammatory disease in general. And sometimes that's how they sort of check, sort of follow your disease pattern. For us, for GI, that correlation for us is patients who have inflammatory bowel disease. And so we follow their CRP and ESR numbers as well to sort of determine when they're having a flare or when their medications aren't working well and how that correlates. And so that can be elevated just in the setting of having a rheumatological sort of inflammatory disease. And so may not for you, may not be in the setting of diet, but can most likely, I think would probably, especially with the diet that you're describing, is most likely in the setting of sort of the rheumatologic sort of disorder in general.
Thank you very, very much for that, doctor. And let's go now to Michelle. Michelle, welcome.
Hi, thank you. Doctor, I joined a little bit late, so I'm not sure if you referred to the study where they took the obese mouse and the skinny mouse and they injected the microbiomes and switched them, and they were able to, by changing microbiome, make the fat mouse skinny. And I'm interested in your opinion. If somebody is morbidly obese and their first choice would be to try to find the resolve and the support systems to do it through a whole food plant-based diet, like if we kind of refer to that mouse study, in your opinion, is that possible? Like, do you think it's actually clinically possible for a very morbidly obese person who's been that way for, a couple of decades to get that kind of result, like the obese mouse that became a skinny mouse, just by feeding and nurturing a healthy microbiome?
So, and I'm not sure if the question is whether just injecting a microbiome or changing the diet. So I'll address both of them. I didn't talk about that study, but I was like, okay, I got to give these people a break and not go too crazy. But I did talk about microbiome because I love the microbiome. And I think it's down the line that's going to be very helpful in precision medicine. And I also love that study too. So the one thing is, I think that we're The simpler of those questions is whether we can sort of inject sort of a healthy microbiome into a patient that has obesity to sort of help them lose weight. I don't think we're there yet. I think there are a lot of studies, some of which that I was sort of being able to do with my patients to be able to understand sort of what is a common microbiome makeup of patients that are afflicted with excess weight versus a patient that has sort of a quote unquote normal or healthy weight. And so we do know that there are some changes, but the problem is right now, sort of the microbiome data is sort of like the tip of the iceberg. We don't know sort of everything underneath there yet. So we don't know exactly what strains, how much, and sort of so those are things we just don't know. The only thing we know right now is to sort of try to get the most diversity possible. And to sort of, and we know how to change diversity. It's with sort of a whole foods and a plant-based diet, with a diet that's mostly fiber and with reduced processed foods. The second part of that question was about if we think you could change a patient that has morbid obesity with just a whole food plant-based diet. So that one is far more complicated because it depends on all the other factors that likely contributed for that patient. So what medications are they on? What are their genetics? What are their epigenetics? Sort of what are they intaking? What is their caloric intake? How much are they sleeping? How much stress? So do I think that is a step in the right direction and will certainly help? Yes. Will it be sort of the ends all be all? Maybe not. And in some of those patients in my practice, that's where we for sure start. We start with dietary changes before we do sort of anything else, is understanding food, because that is going to be what sustains you. It's understanding how much we're eating, understanding what labels mean, understanding how preparing meals and foods and preparing your plate, how to set ratios of your plate, overcoming sort of those emotional eating sort of habits, over listening to your body and being mindful and slowing down when you're eating, paying attention to those things and sort of getting GI symptoms under control. And so I think always starting there is super important. But for a lot of patients, they may need something. If they're having morbid obesity, they may need a little bit more. But I think that background, that foundation is sort of imperative, especially if they're going to sustain that weight loss, because I can't tell you how many patients that I've seen that have had a gastric bypass and initially lost weight, but now they've gained it all back and then some. And it's because that sort of foundation was not there to begin with for them to be able to grow upon, because life is going to always happen and you're going to still have insults. Pandemic was a big one for people, but death in the family, changing a job, some kid coming to live back in your house again, all these other things that can happen that throw your life completely off track. So getting people to understand what those coping mechanisms are going to be, how to institute them, and sort of what their strengths are going to be and what they're going to need to lean on when life inevitably happens. So I think it's not as simple as just a whole food plant-based diet. I think that's going to be major. And most patients will tell me, even though they've only lost maybe 5 or 7 pounds, and when we first start with that, they tell me how much more energy they have. They're able to sleep better. Their joints feel better with just minimum amounts of weight loss, just with those dietary changes. They're not bloated. They're not fatigued. They're not tired all day long. They wake up feeling more ready to go, more invigorated. And so once I get people to feel those things, it's almost like I got them. They're saying, oh yeah, I can feel better. This is great. This is even better. I call them non-scale wins. So having those non-scale wins are super important.
Thanks very, very much for that, Doctor. And let's go now to Andrew. Welcome, Andrew.
Thank you. Great presentation today, Doctor. Really appreciate it. With regards to Crohn's disease, what is your opinion with whole grains, both with and without gluten, on patients with Crohn's disease? And other than the blood biomarkers like CRP and then stool like calprotectin, what symptoms should a patient with Crohn's disease look for, with specifically to like when eating whole grains, as far as, are these good or bad for me? Or does it really, if a patient doesn't experience those symptoms, does that mean the food is a go, or does it really should go to those blood biomarkers? Thank you.
Yeah, good question. Let's see. So with Crohn's, so for people who don't know, Crohn's can affect anywhere in the GI tract. So that one is very different than ulcerative colitis. So when a patient has Crohn's disease, what symptoms they're going to have is dependent upon where in their GI tract they have symptoms. So some patients will only have colonic disease or rectal disease, where they have a lot of bloody stools or diarrhea, that sort of thing, or mucousy stools. Some patients will have Crohn's that is sort of primarily in their terminal ileum or in their small bowel. They can cause strictures strictures are narrowing. So those patients can get bloating, and they feel like they can't pass through it at all, and they have a lot of nausea or vomiting because of those strictures. Some patients can have what's called fistulizing disease, where they have sort of their colon can sort of connect to their vaginal wall, where they poop urine, like from their urinary tract, they can have poop. They can have it to their skin, which is called a cutaneous fistula. So it can happen anywhere in the GI tract. So that's the first thing. So whether people are having symptoms are dependent upon, or what symptoms to look out for, depends on where your disease is sort of mostly throughout your GI tract. So that's the first piece. The other piece when we talk about diet and my patients with IBD is to think to the gluten sort of issue. And that's a whole other topic there, because a lot of patients, often I'll tell patients it's probably not the gluten that's causing you problems, because usually we are going to be doing biopsies to look for celiac disease, to look for any other actual sort of gluten allergy. But most of my patients that have a sensitivity is usually not the gluten. It's usually the other processed stuff in the food with the gluten itself. And so when I get patients, I had a patient just yesterday that was, I was just sort of, let's just switch your bread a little bit. So now she's on an Ezekiel bread. So let's have something that's actually a whole grain. And she goes, I thought I couldn't tolerate gluten. It was clearly the fact that I was eating processed grains and processed foods with a bunch of other emulsifiers and additives that were causing her to have symptoms, because the Ezekiel bread works just fine. Or patients will tell me when they traveled abroad, I can eat pasta when I'm in Italy. What is wrong with me? When I have pasta in the US, it feels terrible. It's not the gluten then. It's sort of the things that we're allowing sort of in this country to put in our foods, those emulsifiers we talked about that cause people to have a lot of these symptoms. So with that one, I would say sort of paying attention to those food labels, looking for those major emulsifiers like polysorbate 80, carrageenan, carboxymethylcellulose, all of those different guar gums and lecithins that we see. These are all things that we'll see sort of ubiquitous in a lot of our foods that cause us to have a lot of symptoms. Another thing you asked was about other markers. So typically, even if I have a patient that's in a remission, at least every 6 months to a year, we're going to be checking fecal calprotectin, CRP, ESR, checking their vitamin levels, because I know with Crohn's disease, you sometimes don't absorb certain nutrients from your food well. So calcium, vitamin D, iron, magnesium, B12, folate, these are all things we're going to be checking and sort of give us an overall picture, in addition to what you're telling us you feel, how many stools you're having a day, if you're seeing blood, if you're having nausea, vomiting, bloating, if you're able to have a good appetite, if you have good energy. Because if you're not having those things and I see your blood count's a little bit low, your iron's a little bit low, that telling me you're probably losing a little bit of blood somewhere and something's not going great. If your fecal calprotectin, those things are also elevated. And sometimes and it's good to know that baseline too, because sometimes I'll have patients that don't mount the CRP response, but it doesn't mean they're not having a flare. So they tell me they're having symptoms. We end up taking a look with a colonoscopy and I'm like, oh yeah, definitely a flare. So I think, and the other answer to that is, so figuring out sort of knowing what those ingredient labels are showing, and then listening to your body to see sort of what causes you symptoms and what doesn't.